Good evening everyone. Today I am presenting a case of post-renal transplant, 64-year Hindu male. He presented to the hospital with the chief complaints of swelling of bilateral lower limb since 10 days and worsening of renal parameter. So I would like to date back my history to 20 years back when he was first found to have increased blood sugar level on the routine investigation. At that time his blood pressure was also above the normal limit. So he was started with 2 oral antihypoglycemic agent and 2 antihypertensive medications. He was on regular follow-up and his blood sugar and blood pressure level maintained within the normal limits with these medications. In 2018, he was first told to have that he was leaking protein in the urine and his creatinine was around 1.3. At the same time, his BP was uncontrolled, so his antihypertensive medication was stepped up from 2 medications to 4 medications. The fundoscopy was done at that time, and it was there was no there is no retinopathy at that time. Within 1 year, his creatinine went up to around 3.5, and in 2022, it was around 6. At that time, he was counseled for the fistula and the future requirement of RRT. So in October 2022, he had an episode of pneumonia for which he was hospitalized. His creatinine increased from 6 to 8, and he also developed swelling of bilateral lower limb plus difficulty of breathing, for which he was started on dialysis via IJ catheterization. He was discharged after recovery but continued on dialysis. His urine output was 500 to 600 ml per day at that time period. So he went to Kolkata and underwent live donor related kidney transplant on 30th of December 2022. Donor being unrelated, blood group of the donor was same as per his, and that is blood group B. He gave no history of previous blood transfusion. He underwent 5 sessions of plasma exchange before transplant and given injection ATG on the day of transplant. On the immediate post-transplant period, his urine output was good, around 2.5 to 3 liter per day. His creatinine gradually decreased, and Follies removed before the discharge, and he discharged on post-operative day of 7 with the serum creatinine of 1. He was continued with triple immunosuppression, that is steroid, cyclosporine and azuran. For 3 years he has stable renal function. On January 2025 he developed again an episode of pneumonia and his creatinine increased to 3.9. He underwent kidney biopsy at that time period which revealed mixed rejection. So he received 14 sessions of Plex plus IVIG and his creatinine came down to 1.8. For 6 months his creatinine remained between 2 to 2.3. Then his creatinine started to increase to 2.6 in the previous month and now it's around 3.9. And he also developed swelling of bilateral lower limb since 10 days, which was gradual in onset, progressive in nature and bilaterally equal, and it was aggravated on prolonged standing. So now he is advised for kidney biopsy for further management, for the follow-up. So that's the present history. And past history, sir.
Okay, I'll just take a second. Yes. What was his education level? What does he do?
Sir, businessman. Occupation wise, he is a businessman, sir.
Education?
Education, sir, graduate.
Graduate. He used the term mixed rejection?
Yes.
It's a history. So again, these are things which tempt you to use statements which are only in the documents. So ये होता नहीं है ना. He can only tell you rejection था या नहीं था. Second is, your history is fine as it is, the way you have presented. It's very time consuming. If I were in your place, of course, we'll take sir's opinion also, I would have curtailed the pre-transplant history. That he was diagnosed as diabetic and hypertensive. He was started, gradually increased medication and he progressed on to ESRD on so-and-so date. AV fistula was made, no blood transfusion was went and he decided to go for living. It cuts down your time period. Alright? क्यों sir? ठीक है ना? Again, It is a matter of what you're presenting. You know, if there was some relevant history in that first part, he was hepatitis B positive, or he had multiple transfusions, or it was a female with pregnancy, then it's a different matter. Otherwise, it's an insignificant part of the history, that part. Don't use scientific terminology in your presentation unless the patient has used it. All right? So you're finished with your presenting update?
Yes, sir.
You're finished? Anything, sir?
No, she'll just sum it up again.
Just summarize.
Yes, so for whatever you have...
Sir, 64-year-old male with past history of diabetes, developed diabetic nephropathy in 2018, and there is progressive decline of renal...
There is no past history. Diabetics remain diabetics for life. So it's a diabetic.
Diabetes. There is progressive decline of the renal function over 4 years, and he developed pneumonia and started on dialysis due to fluid overload. He underwent life-related renal transplant from an unrelated donor on 30th of December 2022 after 5 sessions of Plex and IVIG and ATG induction. Maintenance immune suppressants were steroid, cyclosporine and azathioprine. 3-year post-transplant, he had pneumonia and acute graft dysfunction. Biopsy was done which showed mixed rejection. Then he was treated with plasma exchange plus IVIG. Now again his creatinine is increasing and he has developed swelling of bilateral lower limb, and now he has advised for kidney biopsy.
Has she missed anything very important in the history? You have to listen. Just because she is presenting, you are not exempt from questions. What have you missed? Is plasmapheresis a routine induction for any kind of transplant?
No, sir.
So you have not given any reasoning why plasmapheresis was done. Was the patient sensitized? So either you say that I asked the patient and he was not aware. That's an important part of the history, right? The moment an examiner hears plasmapheresis pre-transplant, it means what? Either ABO incompatibility or
HLA incompatibility or ABO incompatibility.
So
or
then you have had to, you should have had the history. Was DSA done? Was flow cytometry done? Was it the first donor they selected or somebody else? Right? So this is an important part of the history. So when you ramble around about a lot of unnecessary things, you miss these things. Right? What else have you missed? You have given the immunosuppression. What happened to his diabetes post-transplant? Did he require insulin? Did it become worse? What was it? What happened to his hypertension after transplant? Was it well controlled? Was it not well controlled? You have missed that part of the history, right? You have missed the diabetes. 100% if he has been given this kind of therapy, he would have had this thing. What kind of pneumonia was it that it would lead to a rise in creatinine?
So it was bad.
It was bad pneumonia, not good pneumonia. Was there sepsis?
Double pneumonia.
No, sir, bacterial.
So what was the point? See, what was the pathology? What was the diagnosis? Did he receive IV antibiotics? Was he put on ventilator? Right? So these are important things which you want to know. After all, rise of a creatinine is a very important parameter, right? And during that time, was his immunosuppression stopped? You haven't asked that history. If it was that bad a thing, was he given additional immunosuppression, or they said that okay, we'll have to taper down because the pneumonia is not coming under control? Right? These are again relevant histories which you have forgotten. Give, sir.
So, Priti, did you say that the mixed rejection followed the episode of pneumonia?
Sure.
That is why what Dr. Mukherjee is pointing towards is important. But before that, I mean, of course, one aspect is why was he given all that which is not routinely given to a transplant patient? And secondly, equally important, what is typically the immunosuppression you use? in a patient?
Sir, in our setup we use tacrolimus, steroid and MMF.
Right. So you said it was not tacrolimus, it was cyclosporin.
Yes, sir.
It was not MMF, it was azathioprine. So did you try to ask the reason why the patient was not on the standard of care in 2025? This is what we used to do when we were your stage. Like, so we didn't have tacrolimus, we didn't have MMF, and we were putting all our patients on cyclosporin, azathioprine and prednisolone. So any particular reason why you would want to guess as to what went on in the nephrologist's mind there to go in for such a regime?
Sir, whenever we prefer azathioprine, if there is any infections or if there is any side effects related to MMF, then we will prefer azathioprine. Otherwise,
Cyclosporin is what he's asking.
cyclosporin, sir, TAC related TMA. If
Right. So you should have inquired, been more inquisitive as to why. Did they change it? Was it a de novo
Sir.
kind of immunosuppression
yes, sir,
protocol?
I asked, sir. He was put on these medications since day one, sir.
On day one. So it was not changed. It was not as an afterthought. It was not out of compulsion, right? So when you say infections, don't believe that azathioprine and gives you a lesser incidence of infection. So this is an antimetabolite. This is very potent. The fact that it is cheaper does not mean it is less potent. It is quite a potent medication, and infection rate would be similar. The so many other things which go along, immunosuppressive things, go hand in hand with azathioprine as well. Cyclosporin, yes, it could be, you could say, a nephrologist's choice, a center preference, but I think 90% of the times world over it is going to be tacrolimus, and it is only a conversion from tacrolimus to cyclosporin rather than an upfront de novo kind of situation.
Yes, sir.
Right? One reason you could have given was the incidence of okay, let's say what are the typical differences between tacrolimus and cyclosporin. So this is related to their cosmetic effects. Obviously you may not want to use cyclosporin in a female. It is also something to do with the relative chances of TMA. It is something to do with the potency. You know, tacrolimus is much 100 times more potent.
Yes.
And it is also something to do with the risk of hypercholesterolemia, hyperuricemia, and the chances of statin-induced myopathy. All right. So all these things differentiate typically where one scores over the other. Right. And the fact that world over majority of the people are currently using tacrolimus means that must be supposedly a better immunosuppressive thing. So why was it used is something you should always ponder. Whenever something happens out of ordinary, so you must give more thought to it. Okay. So any questions from the audience here? Any more information you would want to seek from her? Because ultimately we have to collectively make a diagnosis here. Right? All right. Any other?
Third year, what else would you have wanted to know? थर्ड ईयर कौन, इसमें और क्या जानना चाहोगे? चलो, I'll give you a hint regarding the immunosuppression. बताओ.
TAC levels and cyclosporin levels.
That's absolutely, and more importantly,
Leukopenia incidence.
how will you know leukopenia? How many days prior to transplant was the immunosuppression started? Was it given, if 5 sessions of Plex has been given, means it's 1.5 weeks pre-transplant, correct? So, was it started day -2, day -3, day -7? That will give you an indication why, one of the reasons. Besides, as I said, center preference or nephrologist experience. Some people just feel that this is better.
And at the same time, not to confuse you, the young impressionable minds here, so many times the whims and fantasies of a given center, sorry, I don't ordinarily want to criticize someone in their absence, but then so many times it may not be an appropriate kind of decision, which means you may believe that, and this is what we experience very often from people who come back from there, that the mere increase in MFI value of just about 1200, 1300 may compel a given team there to subject the patient to many plasma exchanges, which you may find little maybe inappropriate, but then that has been happening, and that too where the cross match was plumb negative, both CDC as well as flow cross match. So I think let's not look too much into why it was done, because we have seen such a scenario taking place otherwise, but then for you it should be very clear, as Dr. Mukherjee was asking, the very fact that a plasma exchange was done, which means there has to be a start point and end point to it as well. You will not say that, okay, I am going to do a plasma exchange for this particular indication, and then you just go ahead and do the transplant, whereby you are on one hand talking about it being a difficult situation to tackle, and you end up giving an immunosuppression which is not as robust or as strong as the conventional TAC MMF. Alright, so there is I think a little bit of disconnect here, whereby on one hand you are being very aggressive, and for the induction and for the maintenance you are going relatively taking a middle path. All right, so let's move on. Any other questions? So all these things are important, but I think important thing to know here is everything went according to the plan as far as the transplant was concerned. So we can believe that it was a straightforward transplant, since we don't have any reason to believe as to why the plasma exchanges were done and IVIG was given. But anyways, the transplant took place and it was a smooth course from what I gather from you, for the next about 3 years. Is that correct?
Yes, sir.
All right. Till such time that something happens. Okay, you want to throw more light via the examination before we move on to the discussion?
Anything in the past history, family history which is relevant, say so, otherwise leave it.
So the important thing, Preeti, for you would be that, like Sir has asked you here, here is a diabetic patient who was subjected to transplantation. You will have to say that this patient underwent transplantation. His basic diagnosis is presumed diabetic kidney disease. You can use the word presumed because they didn't do the biopsy. Yes, so it is presumed. And in the same breath you will say, I have no reason to believe that it could have been something else. What stops a 60-year-old who was 55 then, right? 54 now? Sorry.
Now he is 64, sir.
He is 64 now and was 58 then, in 2018 was 57. Nothing stops a 57-year-old from having things like MGRS, or it could have been a membranous nephropathy more commonly, a missed diagnosis of FSGS, membranous nephropathy. I will even go to the extent nothing stops him having even an missed diagnosis of IgA nephropathy.
Yes.
Right, although you will not be wanting to mention IgA nephropathy as the first thing, but then whenever you talk about diabetics, you are always going to rule out things like membranous, FSGS, multiple myeloma or MGRS, and of course IgA nephropathy and a whole lot of other things. And you will say, I have nothing to believe because he behaved quite typical of diabetic kidney disease. All right? And please, we should not be using the word diabetic nephropathy because this is just about semantics now. In 2025, I mean, let's adapt and let's go with the flow and start using the word diabetic kidney disease rather than just limiting ourselves to diabetic nephropathy, which I am sure everyone here knows. So let's move on and talk about the examination, if that throws any further light.
Sir, past history, family history, only past history is significant diabetic and hypertensive since a prolonged period of time of 20 years. Otherwise, there is no significant family history.
Did you mention about retina?
Retina, sir, fundoscopy was normal
Right.
till that.
Okay.
Then, sir, on examination, sir, I have to say he is conscious oriented to time place person. His pulse rate is 86 per minute, regular, rhythmic, normal in volume, no radioradial or radiofemoral delay. Arterial wall was just palpable. BP is checked in all four limbs. Right arm supine position, it is 140 by 70 mm of Hg. Left arm supine position, it's 140 by 60 mm of Hg. Right leg, it's 160 by 80, and left leg, it's around 150 by 80. Then respiratory rate is 18 per minute, thoracoabdominal, temperature is 98.4 degree Fahrenheit. There is no pallor, cyanosis, clubbing or raised JBP, lymphadenopathy. Edema is present, pitting in nature. Then, sir, nothing significant.
Okay. What is something very important you have missed, which if I was the examiner, I would be extremely cut up with you? And all of you, because you have also missed it.
Scar mark, sir. Scar mark.
What?
Scar mark.
Yes.
About
About to say when? After the exam is over.
scar mark.
And?
Something felt below the scar mark?
Any?
Is something there under the skin where you feel the scar? Can you feel the graft?
हाँ जी सर.
है बोलना उसके बारे में बता दो बेचारे के बारे में, because we are discussing in absentia about that particular.
Then I was about to say it
Surgical
is a systemic
scar you have
exam.
not mentioned. IJV insertion point scar you have not mentioned.
Okay.
You have not mentioned the palpatory findings of the kidney. Major issues.
And always make it a habit to auscultate the graft as well,
Yes.
for the presence or absence of graft bruit. Right, so not too many people these days we are doing that. You must, because and many a times you may actually be able to appreciate that bruit, which may not be of much clinical significance. So it's only once you keep on doing it will you be able to differentiate whether to give any kind of importance, because so many times you'll feel there will be a faint bruit.
Older generation examiners will get up and put their steth on the patient. And if he catches a finding which you have missed, वो तुम बाकी बैंड क्लासिफिकेशन वगैरह भूल जाओ, एग्जामिनेशन फिनिशेस देयर. सो डोंट मिस क्लिनिकल फाइंडिंग्स. ओके, डोंट मिस looking at the retina. You are supposed to be able to see. You can always say undilated pupil, limited examination could be done. But as a physician who has become a nephrologist, there is nothing stopping you. Okay? Urine examinations, all these things have to be done. It is kept there. Okay?
So one tip for your exams would be, rather than going into any kind of controversies and trying to reflect upon the educational status or the awareness of this thing, just say that patient is aware of the fact that his biopsy had shown some rejection, which, rather than being so very particular, which even many doctors may not be able to know what is mixed rejection or this thing. So the whole flavor gets changed. If you had just said that patient had graft dysfunction, for which he went to his doctor, a biopsy was done, which according to the patient showed evidence of rejection, and he was treated accordingly. So play diplomatic, you can give all the information, but you can't blindly know. Maybe he just overheard someone saying that it is some kind of mixed rejection, and it may not actually have been that. So
Okay.
just say rejection. So okay, so where are we now at the moment? Has a biopsy been done, a repeat biopsy?
Sir, not yet, sir.
Not yet. So is being planned for a repeat biopsy, and at the moment patient is admitted in the hospital
Now admitted.
for worsening renal function.
Yes.
All right. Now if you want to sum up and give us your differential diagnosis.
Sir, the diagnosis would be life-related renal allograft transplant.
Live?
Unrelated, sorry. live unrelated renal allograft transplant, ABO compatible, donor being unrelated, induction ATG, desensitization plaques on triple immunosuppression, discharge creatinine is 1. Now sir, acute on chronic graft dysfunction, acute factor being most probably sir, I would like to keep rejection. Then sir,
No, beta, rejection नहीं बोलोगे ना. Either you have to specify ongoing rejection. So rejection, you've already said the patient was told that he had an episode of rejection based on the previous biopsy. So which means biopsy has been done and the diagnosis is made. So why are we discussing the case today? So you have to take it from there where the biopsy was performed, some information collected, action taken. In spite of that, the patient is in the hospital today. What brings him to the hospital? Alright, so that is your diagnosis. So everything else is summing up the basis. You've said renal allograft recipient, fine. Triple immunosuppression, okay. Good graft function till recent. Present diagnosis, we'll say. In the background of a renal allograft recipient, blah blah blah, and now the present episode is of, what will you say? Is it rejection?
sir, first I would like to keep rejection.
So then you'll say ongoing rejection or resistant refraction, refractory rejection. So you will have to use some word, some adjective to it. Okay, then?
Then sir, second I would like to keep BK virus infection. Then sir, maybe sir, due to the recurrence of diabetic nephropathy, either recurrence or de novo. Then sir, chronic factor may be IFTA.
See, you can't just put, sorry,
Please.
you can't just put differential diagnosis like this, okay? Now tell me, which BK virus would a nephrologist have given additional immunosuppression and plasmapheresis? You had a biopsy, right? Even though you don't know the biopsy, it has been treated by a nephrologist. How do you say BK virus? You'll have to justify, right? One. Yeah, no, so unless you say it developed later, causing worsening of graft function.
So maybe this is what she may have meant, and I think maybe, okay, to your support, I may have this argument that this patient had some kind of rejection, was treated, and has not shown improvement. So there are various reasons as to why. One of the reasons can be it did not respond. That rejection was bad enough not to respond to that treatment. That's number one. Secondly, at the time when we set upon treating the rejection, something additional happened, and that is when you bring in BK virus, which is a very common entity, which is very common scenario, because you would go by a good pathologist report, which will invariably in 2025, at least that is what I expect from a good pathologist, to mention that there is no morphological evidence of BK virus nephropathy. You should not, and that's a very important message I would want to give to everyone, never be trigger happy and never jump onto steroids, etc., or up your immunosuppression protocol unless you have ruled out BK virus and also CMV, because you would invariably end up burning your fingers. I have done it. So I must tell you where I faltered and created a bad situation for my patients, where you just went blindly by that report of acute rejection, and that acute rejection may actually have been a mimicry by BK virus. Alright, so that's point number one. And secondly, you said you are believing that everything happened just recently as a part of pneumonia. So, okay, if I may ask you, what kind of things you can imagine could have caused acute graft dysfunction related to pneumonia?
Sir, first maybe said due to any pre-renal cause, sepsis or anything. Then sir, renal cause, sepsis itself, infection itself, or any concurrent nephrotoxic drug use. Then sir, second I would like to give rejection.
Any, see, you're a nephrologist. So a transplant physician, transplant infectious disease, the first thing when you say your patient has pneumonia, what should come to your mind? Beyond influenza, swine flu?
PCP sir, PCP
right?
pneumonia.
Okay, PCP is one. But before
Fungal.
that? Anyone? CMV. Think of cytomegalovirus. We have to correlate. You have correlated by saying that okay, the patient became sick, had pre-renal azotemia. Fair enough. Patient had sepsis, had acute tubular necrosis or ATIN. Quite well taken. Now you have to correlate, knit everything together, and when you knit, you have to have a common etiology for the renal as well as the lungs. And the first thing which should come to your mind is CMV. Alright? There are few others as well. So any pneumonia whereby you can have some kind of renal toxicity as well.
IRGN, sir.
No, that will be immunological. That will be as a consequence after a few weeks. Sorry? Mucor, okay, mucor, but generally disseminated mucor, but we generally would see if it is a lung mucor, it will stay that while the renal mucor most of the times has been described as an isolated pathology, isolated renal mucormycosis, which has even been seen in immunocompetent people, right? What you see in typically mucormycosis in the lungs, pulmonary, is typically in a patient who is actually immunocompromised, and you have either pulmonary or something in the vicinity that is GI. So things like Legionella, things like staphylococcal. So these things, few where you can have both. Could it be a pulmonary renal syndrome? You see, you always presumed that this was diabetic nephropathy. What if it was ANCA-associated vasculitis 7 years ago, and he is having a pulmonary involvement, he is having a renal involvement? At least think on those lines. All right. So you may say in your diagnosis, I don't think it is pulmonary renal syndrome, because that's a different thing altogether. Rather than saying that okay, patient had PCP, you gave Septron, and that is why the kidneys failed. That is not a pulmonary renal syndrome, right? So, get my point? Okay. Then what are the other differential diagnoses? You are presuming that as I said earlier, that everything happened with the episode of pneumonia. You will have to keep the possibility that maybe this gentleman was not on a very robust immunosuppression. While on cyclosporin and azathioprine, there was a possibility that this patient had underlying chronic graft dysfunction, chronic rejection. All right. So at this stage, so let's brush up our knowledge of these definitions. All right. So about rejection. So if someone can volunteer, we'll start from you. So when she says acute rejection, what things come to your mind? The timing of the rejection, all right, and the presentation of the rejection.
It will happen within the first week.
No, not really. I mean, it is not a must for any rejection to happen within the first 1 week. You only say the peak is initial, but then the risk continues for another 6 months to 1 year. So that is why you divide into rejections occurring in the first 1 year and beyond 1 year. So that's the kind of time frame you have in mind. All right. So any acute deterioration in the graft function which has been corroborated by pathological equivalent is called acute rejection. All right. And it can be cellular, it can be antibody mediated. All right. While chronic rejection, what are the varieties of chronic rejection you know of? And that's why I brought this up in this particular case. Chronic rejection, rejection is immunological. So I'm not saying chronic graft dysfunction. So that's a different thing where you say chronic graft dysfunction or IFTA or whatever name you give. It used to be called chronic rejection, then it came in the word chronic allograft dysfunction, chronic allograft injury, chronic in IFTA now. Alright. So that is like where there are non-immunological causes like CNIs and BK virus and CMVs and drugs, and that's one. While immunological are the chronic rejection. Alright, so again as I said earlier about semantics, but the concept should be very clear. So rather than कोई आपको बोल दे कि आज से हम इसको ये बोलना शुरू कर देंगे, at least that should not take away the concept from you. Chronic rejection means it happens late, typically after 1 year, slow indolent process, and is of 3 varieties. Which are these? Chronic active antibody mediated rejection, chronic inactive antibody rejection, and chronic T cell mediated rejection. So all these are chronic. So chronic antibody, chronic T cell, alright, which happens late, and this thing. And there are no specific symptoms related to acute rejection. Don't expect your favorite patient will have graft tenderness always, fever always, a reduction in urine output. No, nothing may happen. Very, very subtle features, just a vague feeling or not feeling well is all it takes for you to be alerted to the possibility of acute rejection. And how will you prove or disprove? No, the creatinine will increase. How much of creatinine do you expect to increase before you label someone as having acute rejection? 25% of the baseline. If it happens, you should be alert to the possibility of acute rejection. It may be something else as well. It could be obstructive uropathy, it could be transplant renal artery stenosis, but then yes, it could be rejection. On top of that, what else happens? So creatinine has gone up, GFR has fallen, what else? Urine output may or may not reduce. Anything? Proteinuria more than 1 grams. Pyuria, आपने देखा हर बारी pyuria थोड़े से पश्चात आ जाते, that doesn't mean UTI. So that could well mean acute rejection. It may be UTI also, I'm not denying that, but in acute rejection episodes, you will have subtle symptoms, persistently elevated serum creatinine, 25% more than the baseline, proteinuria more than 1 gram, and some degree of pyuria. All right, this is all will make as the same. Now, third years, hands again. Third years. So third year, just quickly tell us about the classification. BAMF. What do you mean by borderline rejection? What do you mean by type 1A, type 1B, 2A, 2B? ये तो आधी रात को कुछ क्वेश्चंस हैं जो 12 बजे ऐसे उठाऊं तो आपको पटाप से एकदम से शुरू हो जाना चाहिए. So you are not to be excused if you don't know about BAMF classification. बोलो जी. Second, third year 2, third year 3, third year. कौन है third year सारे? हाँ, third year please.
Sir, borderline rejection is mild tubulitis, T1, any type of.
ना tubulitis नहीं बोलना, यहीं से फिर जो ना इससे नहीं बोलना, I से start करना है. Always start from I.
Any interstitial inflammation with T1 or
so 25%. Borderline is less than 25%. All right. So whereby the interstitium is I1. Remember, ये चीजें रट लो. ये सारी उम्र ये बोलनी. I1 with any degree of tubulitis 1 to 3 याद रहेगा. I1 के साथ जो मर्जी खड़ा कर दो, T1, T2, T3. या I को थोड़ा सा बढ़ा दो, I2 कर दो और T1 कर दो. तो एक को बढ़ा दो, इंटरस्टिशियम बढ़ा दो, T1 कर दो. रिमेंबर, याद रहेगा. Now who will tell us about type 1A?
T2, any degree of type.
फिर T2 पे आ गए.
Mild, moderate tubulitis with.
पहले बोलना इंटरस्टिशियम में. स्टार्ट करो, एक तरफ से शुरू हो जाओगे ना, I से स्टार्ट करो ना. So type 1 is I2 और I3. I2 और I3 उसके साथ ट्यूबुलाइटिस 1 कर दो और टाइप 1 में ट्यूबुलाइटिस बढ़ा दो. तो आसान है, इतना मुश्किल नहीं है जब एक बार कॉन्सेप्ट पता लग जाते हैं तो।
Grade 1B severe tuberculosis. मतलब interstitial severe tuberculosis.
क्लियर होगी बात अब? सो यू विल स्टार्ट अगेन, ये याद रहेगा अब, इंटरस्टिशियम I1 is borderline with any degree of tubulitis, tubulitis 1, T1, T2, T3. That is the importance you want to give to interstitium, right? Type 1A is interstitium I2, I3, but अगर T1 आ गया है तो वो type 1A है, tubulitis type T3 आ गया है तो it's a severe. Why it is important is because your treatment will change, all right? And now tell us type 2, third year, और कौन है third year यहाँ?
V1.
Yes, so when you reach the V is called type 2. Type 2 is
V1 or V2.
V1, हाँ? V1 और V2 मतलब अभी transmural arteritis नहीं हुआ है, ठीक है? That is type 3.
25% or 25%.
Yeah, so with any degree of tubulitis, so you have to have tubulitis. That is why you are saying it is T cell mediated. So clear, everyone? So it is about interstitium, it is about tubulitis, it is about vascular. So interstitium होना ही होना है borderline में, and any degree of vascular, any degree of tubulitis. Type 1A and type 1E are more higher degrees of interstitial involvement, I2, I3 with variable degrees of tubulitis. If it is tubulitis 3, it is type 1. T3, it is 1B. All right. While 2A and 2B are when there is a vascular involvement. Your treatment will change. Isliye we'll come back to where she is wanting to lead us to. All right. And type 3 is transmural. It's a gone thing. It's a most dreaded varieties if you know of. All right. Now, if someone can throw more light on, so we have talked about acute rejection. We have talked about chronic rejection. We have not still talked about antibody mediated rejection. So someone can tell us about the BAMF classification of acute antibody mediated rejection before we proceed any further. What is it? Second years now? Second years? Kahan hai second years? So tell us about when do you say it is antibody mediated rejection? Yes. So evidence of injury. ठीक है, मतलब बेसिकली घर में आप आए हो, आपने एंटर किया है तो वहां पे तोड़ फोड़ हुई है, तो तोड़ फोड़ हुई है, सो दिस इज इंजरी. ठीक है. द व्हाट डू यू नीड एज अ सेकंड थिंग? चोट लगी है, तोड़ फोड़ हो गई है, अब क्या ढूंढ रहे हो? चोर ढूंढ रहे हो. चोर है कौन सा, क्या है? एंटीबॉडी. एंड तीसरा क्या है? ठीक है. सो इंटरेक्शन ऑफ दैट एंटीबॉडी विद दी इंजरी की है उसने, सो दोनों को जोड़ना ही है ना. सो तोड़फोड़ भी हुई है, चोर भी मिल गया है और दोनों आपस में घुसते लगे हैं, उसका एविडेंस है C4D. Alright, so okay, so these are important because we are now going to discuss about how do you treat and where did they go wrong. I mean, before the patient landed up with her, and where things went wrong and could have been better. Alright. Now finally someone can tell us what is mixed rejection. She has repeatedly been talking about mixed rejection. What is mixed rejection?
Both components.
Obviously, तो क्या उसमें होएगा? So there will be evidence of both there will be glomerulitis, there will be peritubular capillaritis, right? So this takes you towards the antibody, and you have tubulitis, you have interstitial infiltrate, and you can have vascular involvement as well. So the combination of the two is mixed cellular rejection, and let's not be biased because someone could have been wrong in labeling it as a mixed rejection. But if your patient presents with mixed kind of rejection, what does it mean? It means your patient was non-compliant. So patient was non-compliant, yeah, the treating doctor was super confident, all right, in reducing the immunosuppression. So you can't always blame the patient for everything. It could have been the other way around. The patient was told that, look, you are overly immunocompromised, stop all your immunosuppression. And that towards, I would say, the most dreaded kind of patient population are the youngsters, the adolescents. who care a lot about their body, countenance. So obviously they are the ones who may not want to take steroids, may leave this thing. So they are the most dangerous. Remember, and non-compliance is the commonest cause of mixed rejections. So is the commonest cause of so many other things in nephrology, like occurrence of DSAs and the thing. So okay, with this background, Preeti, tell us, what is your diagnosis?
So diagnosis acute on chronic graft dysfunction, and so from starting.
Acute and chronic graft dysfunction. Yes, that's an entity. That is certainly an entity whereby your patient may be harboring chronic rejection, and please, I think you all are aware of the fact that the creatinine may remain normal till very late. You can't say that your patient had come to see me about a month ago, the creatinine was 1.2, that means everything was fine. You forgot to tell us about the proteinuria. And what are the other things which you can do to monitor these patients? What can you do? क्या करना चाहिए? Ideally, you are sitting in one of the most affluent kind of institutes.
Max,
Max is very poor. This thing. So you, because so many people leave Max just because people there are not affording enough, so they go to greener pastures. So what do you can you do to monitor these patients? Very nice. So
Sell the full name. Cell-free DNA. Yes, absolutely.
So क्या cutoff है? If anyone can throw light.
1%.
More than 1% means what? Yes, 1% means what?
Rejection.
मान लिया, what does it translate into? If this patient has more than 1% donor-derived cell-free DNA. हो गया. So what does it mean? That this patient is having may have rejection, and you must know about the positive predictive value and the negative predictive value. The positive predictive value may just be about 64%, but the negative predictive value is 87%. ये आपको figures याद होने चाहिए. अगर किसी ने वो पैथोलॉजी वाली मैम के लेक्चर सुने हैं ना, तो बार बार ये बोलेगी वो 64% and 87%, right? Which means that if you have higher values of cell-free DNA, does not mean it is rejection. It could be rejection, but there could well be pyelonephritis, there could be so many other things as well, and you may not be able to say with conviction that no, don't do a biopsy, this is rejection. However, if the cell-free DNA is negative, you can say with conviction in good 90% of chances that your patient does not have rejection. And that is why people are now wanting to make it even stricter. So not 1%. दूसरा क्या आ गया? 0.75%. 0.5% people say is very, very accurate. And then it's an ongoing thing. Never say that आज 0.5 है. If it is 0.5 today, in the absence of any infection, that becomes 0.75 and that becomes 1, which means there are higher chances of this being rejection. Alright? What else do you monitor? Where money is not the consideration at all. Protocol, very nice. So you should go in for DSAs, because if on one hand you are looking at injury from the cell-free DNA point of view, you can also predict tsunami, as I always say, predict tsunami via getting their DSAs. Whether they are relevant or not, whether they are complementing binding or not, whether they will be pathogenic or not is a different thing. But at least you are monitoring them. So at what level, if money was not the constraint, you will do it at cell-free DNA at 1 month, 3 months, 6 months, 9 months, 12 months. Alright, 1, 3, 6, 9, 12 could be the protocol. Well, you know it's very costly, so you may not actually end up doing that. Same holds true for DSAs, right? And how early can you expect the DNA to increase before there is an evident rejection?
1 month.
Yes, 1 month. It could actually be longer than that, and it could be, I'd say, few weeks to few months, as in this, right? But please go back and read as to when can you expect the rejection to happen after cell-free DNA has been found to be elevated by more than 1%. Clear? So ये सारी करने के बाद प्रीति आप बताइए. So you are right when you say it could be acute and chronic rejection, because there is no way to know whether your patient had anything or not. A protocol biopsy had not been done. Cell-free DNA is not available. You had not tested for DSAs, and your patient was on I would say moderate kind of immunosuppression because of cyclo and aza.
Sir, so even if we have an acute history, should we always say that it was an acute and chronic to be on the safe side?
Unless you are so clear that patient went to the doctor, a biopsy was done, patient did not have any albuminuria, and the creatinine was plumb normal, it was like 0.91, which has gone up to. So no one can contest you when you say acute, but in completeness you may be missing out on chronic rejection, because this acute will not be your complete diagnosis. That's the point I'm wanting to make. Alright. So why BK virus nephropathy? You said BK virus nephropathy.
Sir, because the patient is highly immunosuppressed due to the previous plasma exchange episodes and
Which
also
one? Previous?
plasma.
5 साल में नहीं होते हैं. 5 साल का इतना भी नहीं है ना कि आज आपको कभी आप जो कुछ भी आपको लाइफ में होगा, वो जो हमने 2022 में प्लाज्मा कर दिया, एवरीथिंग इज गुड. वो निमोनिया भी बेचारा 25 में हुआ, वो भी उसकी वजह से. ऐसा तो नहीं करो. You can say, no, everything is important. You have given rituximab, be on the guard for 2 years. You know rituximab effect gets prolonged by 6 months to up to 2 years. Same holds true for ATG, 3 months to 2 years. But 25 थोड़ा सा और आगे निकल गया. So 3 years, not even 2 years. Alright? But yes, you are right. This patient received rejection, anti-rejection therapy then. There is one objection. I will be very happy if someone can point out what mistake was done when they were treating the patient next time.
So the plasma phase is session number 14, sir.
When the first time? This was 22.
So second time.
Second time कितने की है?
So
14 के
हाँ?
14 session sir.
So it should have been at the most 2 to 5, sir. 5 should not be.
मैंने ऑलमोस्ट आपको डिनर ऑफर कर दिया था, जो मैं कभी कभी खिलाता हूँ, बड़े कंजूस हूँ मैं, और फिर मैं वापस ले रहा हूँ. You started off making such good statement. I was so happy with when you said that.
So plasma phase is in chronic rejection, it is.
You get your dinner back. ठीक है? So remember, plasma exchange is a treatment when rejection happens in the first 1 year. There is a role proof of this kind of therapy if given in the first 1 year. So that's why you differentiate. Post 1 year, there is not much of evidence of 2 things. क्या सी 2 चीजें दिमाग में आती हैं? Remember, ATG तो वैसे भी हमने plasma exchange in we are talking about antibody mediated rejection. Plasma exchange उसी में करोगे ना, आप cell mediated में थोड़ा करोगे plasma exchange. So plasma exchange नहीं, IVIG has a role. IVIG has a role. जब कुछ नहीं समझ आएगा तो IVIG आपके रेस्क्यू में आएगा. Alright? Second thing is Eculizumab. तो मत कर देना, मिल गया आपको, अब आ गया सस्ता 70,000 का, और आप कहोगे ला क्रॉनिक रिजेक्शन में हम Eculizumab दे देंगे. ठीक है? So don't use Eculizumab, don't use bortezomib. So clear take home messages today would be plasma exchange has no role in rejections after 1 year. Bortezomib has no role, and the third one, Eculizumab, has no role. The only things which have role are glucocorticoids, and I'm talking about chronic rejection now, beyond 1 year now. Glucocorticoids, IVIG, possible role of rituximab. Alright? Next, BK virus कब पाया गया था पहली बारी वर्ल्ड में? किसके नाम पे है ये?
सर बीके पेशेंट.
ये पेशेंट के नाम पे है या डॉक्टर के नाम पे है या?
पेशेंट के नाम पे है सर.
ओके. कौन सी क्लास को बिलोंग करता है?
पॉलीओमा वायरस.
What are the predisposing factors for getting BK virus nephropathy? Intensity of this thing, 1. So 0, the way we talk about CMV, that graft had a positive CMV, IgG, so D plus R minus kind of situation holds true for BK virus as well. But इतना हम बड़ा बात नहीं करते इसके बारे में. हम किसकी ज़्यादा बात करते हैं? Sorry?
ABO incompatible.
ABO incompatible, very good. So intensity of immunosuppression. Third, ureteral stents, remember this. There is some protection by a few HLAs. Remember कौन से HLA predispose करते हैं, कौन से HLA protect करते हैं. So there is something to do with HLA A, A4, A7, C7, alright?
B9 नहीं, just look it up.
C7, A4. So there are few predisposing factors, and immunosuppression whenever it has to be increased, like giving ATG, giving for treatment of rejections, so the second transplants. So Preeti, हमें बताइए, what are the high immunological risk recipients to your mind? किसको आप बोलते हो हाई इम्यूनो रिस्क है, जिससे आप डरते हो कि ये मैं ट्रांसप्लांट करने जा रही हूँ, ये मेरे को तंग करेगा ये पेशेंट?
Sensitized patients are previous multiple blood transfusions, prior transplant or pregnancy.
So highly sensitized transplant. One. So sensitized. बोलते जाओ, ये तो कॉमन क्वेश्चन है, रोज का क्वेश्चन है, इसमें तो कौन सी रॉकेट साइंस है?
ABO incompatible transplant, HLA sensitized patients.
Common sense. If they have received something
Young recipient, older donor. ठीक है? Young recipient, older donor. Number of mismatches. Second transplant या third transplant. ठीक है? And sorry? History of previous blood transfusion and mismatches. So these are high immunological.
And people who have received cyclophosphamide or immunosuppression, SLE, RPGNs in the recent, they are heavily immunocompromised within the last 1 year.
ठीक है. Husband to wife, yes, you're right, and for that matter, I would say son to mother also. So they were around. ठीक है? So then let's move on and talk about this patient. You said it could be this, it could be second. Could it be CNI toxicity? What are the other things which come to mind?
Sir, could be recurrence of diabetic nephropathy.
Very good. So why you should have kept that possibility as well. All right, patient. But you didn't mention anything about the kind of control the patient had post-transplant of this thing. So can anyone tell us what is PTDM? What term do you want to use? Again, semantics. NODAT or PTDM? कौन कांग्रेस है, कौन बीजेपी है, क्या है? कौन PDTM, कौन NODAT? आज की डेट में PTDM. So we started with PTDM. हम थोड़ा सा दल भटक गए थे. We ventured into NODAT, and then it's homecoming. We're back to PTDM. So you know about the definition. कब होता है? When do you call PTDM? So let's not digress too much. I'm only telling you what I expect from a fellow nephrologist. All right, that you should be very clear about what PTDM is all about. The definition of PTDM. Okay. So the way we have talked about differentiating rejection between first year and second year. Finally, running out of time, Dr. Mukherjee is restless. He knows he is going to take at least 3 hours before he goes back home. So tell us, how do you treat? So there's a reason why I wanted to brush up everyone's knowledge about T1, borderline or type 1, 1A, B. How do you treat any volunteers? How do you treat borderline rejection? Okay, borderline हम बाद में बात करेंगे. How do you treat type 1A acute cellular rejection? Steroids. Then type 1A is with steroids and you increase the immunosuppression. Maybe you had gone low on immunosuppression, go back. 1B?
Steroid.
So 1B?
1B.
So 1A में there are people who may believe that pulse steroid ना दो, मतलब मिथाइल प्रेडनिसोलोन ना दो, ओरल स्टीरॉयड से काम चला लो, मे बी 80 milligram of prednisolone and then people, right? But type 1B you must give methylprednisolone and you can consider using ATG. While in 2A and 2B you must always use ATG because it will not respond, because today only I saw a patient where 2B patient already on dialysis, the person had been stopped just after 3 doses of methylprednisolone. That is not enough. Either you act, it's all or none phenomenon. So rejection ऐसे छोटे मोटे सूरज को दिया दिखा के ठीक नहीं होने वाली कभी भी. So 2A and 2B means ATG. Alright. Type 3 again ATG, but then the results are very poor. Now you tell us, how do you treat antibody mediated rejection? We have already.
Sir.
Yeah.
Active ABMR, plasmapheresis, IVIG, rituximab, then sir bortezomib. No sir.
So ऐसे नहीं शुरू करो. You say that okay, number, this is what I want to do. 1, 2, 3. IVIG क्यों दे रहे हो? Because there is a purpose. आप rituximab क्यों दे रहे हो? और प्लाज्मा कब कर रहे हो? So antibody mediated rejection means it is because of antibodies, whether they are de novo or they are pre-existing antibodies which have increased now in number, MFI. So you are wanting to, number one, remove them.
Remove.
ठीक है? So one is block their action with steroids, remove them with plasmapheresis and reduce the production via rituximab. So these are the 3-prong this thing. When do you give rituximab to these patients? On day 1, day 3, day 5, day 7? None of the above. So what is the catch here?
Rituximab is removed by plasma.
So rituximab निकल जाएगी, पहले दिन rituximab दे दोगे, फिर plasma नहीं करोगे. So only when you want to give a gap of at least 72 hours for rituximab to be able to have its action, will you give. ठीक है? Then what else? Patient नहीं ठीक हुआ.
Then sir we have bortezomib and
चलो, there are not too many big fans of bortezomib, but okay. So, anything else?
eculizumab sir.
Sorry?
Eculizumab.
Eculizumab, yes. So that's again if it is the acute antibody mediated rejection, not chronic this thing, alright? And?
Tocilizumab.
No, अब chronic पार्टी बदल ली आपने?
Yes sir.
So tocilizumab is for chronic rejection. So chronic rejection के लिए then you are talking about drugs like felzartamab, Debabrata and tocilizumab. Alright. So what is tocilizumab?
Sir IL-6 inhibitor.
Receptor and monoclonal antibodies against IL-6. And felzartamab is? Anyone?
Anti-CD38.
Anti-CD38. It does what?
Plasma cell.
As well as natural killer cells. So it blocks the plasma cells, the natural killer cells, and same holds true for Debabrata as well. Alright? And tosi हो गया, ये हो गया. And then you've talked about acute rejection, you've talked about acute rejection. अगर कुछ है सिर्फ nephrologist तो कहेंगे हमने ठीक करके छोड़ना है. You've given Ritux, you've given IVIG, you've given plasma exchange, you've given eculizumab, nothing is working. Huh? Splenectomy. So तो सारा कुछ bone marrow irradiation कर देंगे, splenectomy कर देंगे, they will not stop short of this thing. So this is the way you look at acute rejection. Now you tell us, what do you believe your patient has? With this background information which we have discussed today, where do you put your patient?
Sir, now I suppose chronic active ABMR sir. Now.
अब आप chronic active में आ गए हो, right? So chronic active को, how do you differentiate chronic active from chronic inactive?
Sir, definitive तो will be biopsy, but
कॉन्सेप्ट क्लियर हो, रट्टा नहीं करो कभी, नहीं समझ आएगा कभी, नेफ्रोलॉजी नहीं समझ आएगी, रट्टा नहीं करो. बताइए, एनीवन? बट वो तो एक्टिव, वो तो एक्यूट एंटीबॉडी मीडिएटेड रिजेक्शन में भी आ गया. यहाँ तो हमने वर्ड करानी. सॉरी, या सो एवरी टाइम देयर इज एन इंसल्ट, वो अपने को फुटप्रिंट छोड़ के जाता है. सो एट द लेवल ऑफ द ग्लोमेरुलाई दैट विल बी डुप्लीकेशन, so that will be transplant glomerulopathy. At the level of capillary, the peritubular capillaries, there will be मल्टी लेयरिंग, एवरी टाइम जाएगा तो एक छाप छोड़ जाएगा. इट्स लाइक बार्क ऑफ द ट्री, जितना बूढ़ा होता जाएगा एक लेयर आती रहती है. सो एवरी टाइम देयर इज अ मल्टी लेयरिंग ऑफ दिस थिंग्स. नाउ इफ यू हैव infiltrate, an active infiltrate, you will call chronic active. So in the presence of anything chronic, you have some active cells, it's chronic active antibody. While if there is no such activity, you will call chronic inactive antibody mediated rejection. Clear? Alright? And chronic T cell mediated rejection is a very, very difficult to treat. I tell you, I don't think I have ever been able to salvage too much of a function. Just at best we were lucky to salvage maybe half of it. That's it. Otherwise it's a notorious thing. And all right. Any questions? Any thoughts? Or कुछ? Now you tell me. हमने साइक्लोस्पोरिन इरा की बात की, तो हमें अपना इरा याद आ गया. I mean, we had nothing but cyclosporin and azathioprine to offer to our patients, at least when I was your stage. So there were peculiarities of what we were seeing then, between then and now, the peculiarities. So this is again going back into history a bit. So what do you think are the main changes? Okay, I'll be straight to the point. In terms of malignancies, so what kind of evolution has taken place ever since we moved from, initially there was just, जब हुआ ना वो 1954 वाला transplant, then we just had steroids and azathioprine, right? ये तो cyclosporin तो आई है 80s में, और tacrolimus आई है 90s में, इंडिया में tacrolimus आई है 2004 में. So there has been a paradigm shift, the way we are looking at malignancies. So what is that? Skin to
post-transplant now.
Very good. All right. So cyclosporin is notorious to cause malignancy. पता है आपको क्यों है? एक अपरेगुलेट कर देती है ट्रांसफॉर्मिंग ग्रोथ फैक्टर बीटा को, TGF बीटा को करती है, टैक भी करती है, साइक्लोस्पोरिन भी करती है. So they do it. So they have their own kind of malignancies. They cause different kind of malignancies. Azathioprine would cause more of skin cancers. ट्रेडिशनल ones, ओल्ड ones. कौन से कैंसर्स? अच्छा मुझे बताइए, आपको कैन यू, ओके, सम वॉलंटियर, बोलो जी वॉलंटियर कौन है? क्वेश्चन बाद में पूछूंगा. वॉलंटियर, एनी वॉलंटियर फॉर एन वेरी इजी क्वेश्चन. व्हाट आर दी malignancies you know of पोस्ट ट्रांसप्लांट, जो नाम पटक से आती हैं? अरे ये तो
स्किन कैंसर सर
हो गया. उसी साइड PTLDs, नॉन हॉजकिन लिम्फोमा. बर्किट नहीं है, कुछ और है, मिलता जुलता है कुछ ना, कुछ और. वो तो सारे नॉन हॉजकिन लिम्फोमा हो गए ना. सो मैलिग्नेंसीज बड़ी, हाँ, कैपोसी. भाई बोलो भाई, नेफ्रोलॉजिस्ट लोगों, कैपोसी सार्कोमा को मत भूलो. कैपोसी सार्कोमा, यस. सो क्या इंटरेस्टिंग चीज है इसमें, बताओ. फुल मार्क्स, लंच. हाँ, थर्ड ईयर आपने गंगाराम में सुना था मेरा, इसलिए ये सुना. क्या चीज?
ये ब्रेस्ट एंड प्रोस्टेट नहीं बोल रहे.
ब्रेस्ट एंड प्रोस्टेट नहीं बोल रहे ना, ये गंगाराम में बोला था, यही बोला था. ओके. So I am glad you people remember that. So क्या बोला अभी? Remember this for everyone. दो कैंसर नहीं बोलने हैं. Breast and prostate cancer incidence is actually low post transplant. बाकी सबका ज्यादा होता है, ये सिर्फ दो है जिनका कम होता है. कौन सी malignancies? और कैपोसी, स्किन, हॉजकिन लिम्फोमा. बाकी लिप, वल्वा, एनल, इनमें क्या कॉमन है बताओ? और दे आर ऑल वायरस रिलेटेड, सारे वायरस. कैपोसी कौन सा है? HHV8. PTLD कौन सा है? EBV. स्किन का कौन सा है? वेरी गुड. ह्यूमन पैपिलोमा, वेरी नाइस. ह्यूमन पैपिलोमा इज स्किन. तो सारे तो हो गए. तो कोई कुछ कोई हर्पीस वाला, कोई कुछ वाला, तो हो गया. सो इंटरेस्टिंग थिंग्स, ऑल वायरसेस. एंड इसीलिए हम बात कर रहा हूँ मैं वो साइक्लोस्पोरिन और दिस थिंग, बिकॉज व्हाट हैज बीन हैपनिंग इज द is the increased incidence this thing. So MMF कौन से कैंसर करता है? MMF कौन से करता है कैंसर?
It has some protective role.
इट एज ए प्रोटेक्टिव रोल नहीं करता भाई, क्यों ब्लेम कर रहे हो बेचारे को? सो MMF, द इंसिडेंस ऑफ malignancies has been shown to be little less. कुछ GIT, you are right, कुछ GITs के बारे में होता है. There is a mixed opinion about MMF, but then by and large this is not notorious to cause this thing. Some protective effect also with sirolimus, everolimus, mTOR inhibitors. So remember that. So these are interesting things जो आती हैं. और दूसरी आपको पता ही है किडनी के. So remember, it's very very important, and हमने तो अपने लिख दिया ultrasound every year because polycystic kidneys. ठीक है, normally remember polycystic AD-PKD does not have cancers before transplant. इनमें cancers नहीं होते हैं, but after transplants हो सकते हैं. Alright? Hello. हाँ जी.
Why is Banff classification called Banff?
ओह मैं क्लास ले रहा था.
When was it first classification कब हुआ था?
Of
1991. After that, how many times has it been revised?
46.
Every 2 years.
16 times.
हाँ, कोई
Which
बात
is the
नहीं, no
latest
problem.
one?
21.
No.
24 now, sir.
Yes.
20.
Where was the Banff held in 24? France, Lyons. And what was the major change from 24 between 22 and 24?
That was 22.
Xenotransplant has been added. Rejection of xenotransplant, which was not there in 22. Molecular mechanisms of diagnosis of rejections have come into play in the 24 modification. Remember that Banff is something which, as a nephrologist, if you don't know, it will be very difficult. Rejection, transplant, here you have to know everything.
You have to, no doubt.
Immunosuppressive drugs you have to know inside out. इतना सा है, 5 तो दवाइयाँ हैं यार. Come on, I mean you have to know everything.
Side effects of sirolimus, everolimus.
Sir, proteinuria, poor wound healing, then dyslipidemia.
क्या दूसरा क्या बोला? तीसरा?
Dyslipidemia, sir, lipid problems. Then
एक हर एक ऐड कराएगा, 20 तो हैं, हर एक हिस्से एक आ जाएगा.
Go up.
मुंह में क्या होता है?
ulcers, sir.
स्किन में क्या होता है? स्किन में तो मुंह पे हो गया. स्किन में क्या होता है? एक्नी. और पोटेशियम को क्या होता है? So hyperlipidemia, cholesterol and triglyceridemia, 2 main components. Joint को क्या होता है? Arthritis, arthralgias, edema, not necessarily related to proteinuria, but proteinuria is there, podocytopathy. Next,
Atypical pneumonia.
pneumonia. So interstitial pneumonia. ठीक है? What else?
TMA.
Sorry, TMA. So इसकी तो बात करो ना? TMA. Alright?
Which are the places where you will see a lot of these problems? Everolimus use and causing these problems. Combined liver kidney transplants. Many transplant surgeons, liver transplant, I think sir will bear me out. After few years, once the creatinine starts rising, the liver transplant surgeons tend to immediately stop pangraph, tacrolimus, and switch over to everolimus, and then you will see the rest of the problems coming up. This is very common wherever, because the immunosuppression that time is mainly controlled by the liver transplant people, and you will find that they start switching, and then you will end up with the fresh problems.
Lymphocyles, not just wound healing. Dehiscence, wound delayed healing, lymphocyles.
So whenever you give answer to drug complications, you have to talk about early complications and late complications.
Azoospermia.
Dose related, non-dose.
Whole lot of, एक तो एक चीज आनी चाहिए आपको. And of tacrolimus, the way we started out by saying, what is the difference between the side effect profile of tacrolimus and this thing, and we had not mentioned about the relative risk of PTDM. PTDM is higher with tacrolimus and relatively less with this thing. Cyclosporin has anti-viral properties, so it is protective against both PK virus as well as hepatitis C. Alright, so all these things. So I hope, so now you shoot without questions.
So, recurrence of diabetic nephropathy, suppose this isn't 5 years too early to comment on that?
I think it is possible. So I think nothing stops, because you see, the way we say for pre-transplant settings, it is unpredictable. It is unpredictable from the point of view of the onset of diabetes in an adult. So that is where you are not able to be very categorical in type 2 diabetics the way you are in type 1. That Mazendran classification was for type 1, where you could actually time it. Today this 5 years later, 5 years later, 5 years later. In type 2 it may have been missed, but that is not the only reason why you may have diabetic nephropathy at the time of detection of diabetes. So which means it may take as little as 1 to 2 years, especially if the diabetes has not been well controlled. And there are genetic factors which predispose to people who can get it much earlier. No two diabetics are the same. One may actually make the other one, his friend, diabetic as very complacent because he was protected because of his genes, the other may not be. So dusra banda to gaya. So yes, but she has not kept it as the first and second.
Can't be sure post what exactly was the time when PTDM occurred. We aren't sure pre-transplant, but
here it will not be PTDM. Here it will be like patient was diabetic and patient remains a diabetic.
You can't diagnose PTDM as a
PTDM is not in a diabetic.
sir,
That's a
in
difference.
that we got a kidney from a new donor who wasn't diabetic.
How do you know?
The diabetic nephropathy has occurred in the new kidney.
Right.
So the donor wasn't diabetic to begin.
Agreed. But then in the milieu now in the new kidney. So that is when now these things are going to be determined.
We can
Agreed.
Yeah.
So logic says that, obviously logic says that you will not expect it to be hypertensive nephrosclerosis in the new kidney within 4 or 5 years. Obviously it is all logical to believe that yes, the commonest cause of proteinuria, the commonest cause of graft dysfunction post-transplant is chronic rejection, right? Everything else is. But then so many times we have actually been missing BK virus as the causative factor. So that is why there are people who want to give. Anything else which you can do? We talked about cell-free DNA. We talked about DSAs. Anything else? Would you want to tell us about gene profiling? Have you heard about transplant excellence? Pata? TX and non-TX concepts? So read about that, because that's another way. The gene profiling post-transplantation is one way of monitoring these patients on a long-term this thing. You have heard about that Lupis thing from France, iBox, integrative box. So you know about iBox. So these are the innovations, and it's taking the world forward.
And Dr. Munish Malik's current favorite virus.
That's that is in fact been Max's favorite, which has been on that side. So we started our project with Dr. Lal's, and then
Which one is that? Batao? Toctinovirus, yeah.
So what are the normal values of toctinovirus? Anyone? So this is a pagdandi, you know, pagdandi पे चलना है आपने. The thin rope, you are walking. इधर कुआं, इधर खाई, इधर rejection, इधर infection. So you are on that pagdandi called toctinovirus. So this is 4.6 to 6.6 log 10 value. Alright, so if your toctinovirus, what is toctinovirus? When was it first discovered? So it was way back in 1998 when people thought that they have suddenly found the reason for transfusion hepatitis. So they detected toctinovirus and they thought this was the incriminating agent. So then finally they believed no, it was not. It was a relatively innocuous thing, so it is not causing much. So it faded away. And now after xenotransplantation and after so many recent spurts, people wanted to have a idea as to whether they are over immunocompromising the patient or under immunosuppressing. So 4.6, 6.6. If the toctinovirus exceeds 6.6, which means you have given too much of immunosuppression, the virus is there. And if you give
Mana kuch-
hardly any immunosuppression, the body is able to eradicate toxinovirus. The toxinovirus will be less than 4.6. So you will be comfortably placed between 4.6 to 6.6 log 10. Okay?
Few statistic data you must have, because a lot of Indian data is there on prevalence of BK virus, protocol biopsies, okay, cell-free DNA. There are a lot of big institutions which have given data, graft life, post-transplant, that kind of thing. So these are major articles which are there in Indian Journal of Nephrology or Indian Journal of Transplant, or people who have published in international also. So Indian journals ke kuch major data you should know. Though gone are the days where we didn't have data. We do have data and large scale data.
कितना रिजेक्शन रेट क्या है आजकल? एनीवन? थर्ड ईयर्स इन कॉग्निटिव थर्ड ईयर? कौन रह गया थर्ड ईयर? तो
यही रह गई सर
5 to 7%.
थर्ड ईयर
5 to 7%.
सॉरी
5 to 7.
नहीं कौन सा इंसिडेंस है? ऐसे नहीं भाई, कुछ तो बताना पड़ेगा. सो रिजेक्शन इज बेस्ड ऑन द ईरा. So when we were your stage, the rejection rate used to be terrible, 30 to 40%, and we were finding ourselves giving them all the time steroid, and we had no idea about what BK virus is all about. तो उसी में ठीक हो जाते थे, हम बड़े खुश हो जाते थे, नहीं होते थे चले जाते थे, दूसरा ट्रांसप्लांट हो जाता
सब ठीक है,
right? So now when you are using ATG, the incidence is drastically low. Again, I may be wrong here, but then I think जो मेरे को टॉप ऑफ द माइंड जो याद आ रहा है, it's about 10% in younger would mean 20-30. Then as you move up, that 10% becomes 7%, becomes 6%, becomes 5%, which means as you grow older, the chances of acute rejection will be less. That is why the older people are immunologically less challenging. All right? The younger people are, but 10% chances of in spite of induction with ATG etc. एक चीज रह गई, if ATG doesn't help क्या करोगे in acute cellular rejection? Campath, use Campath. Have you heard about alemtuzumab? Alemtuzumab 30 milligrams single tablet. ठीक है जी? So that is another thing which we had forgotten. So risk of acute rejection पता तो होना चाहिए. We are discussing all the time about rejection. For a 20-year-old 30 ऐसा कुछ करके 10%, 30 to 40 को 7%, 40 to 50 को 6%, and beyond 50 years को आप 5% पे कर दो. So this is the kind of risk profile. And depends upon whether you had used ATG or not. And we had seen when we first started using ATG way back 2003, there was a sharp decline. From 30% we had come down to 20% with basiliximab, and after 20% I think it was just 5%, 7% was our data after ATG.
Look up publications. There are many institutes which have given their patient and graft survival in the cyclosporin era and azathioprine, and then followed up with the next 500 or 1000 transplants in the tacrolimus and ATG era. Broad terms, when you go back, these are difficult things to look up every time. Just note it down in one place and just put it in your book that these are the statistical data, because if you are doing well, your examiner will ask you. The moment an examiner starts asking about studies and all, means you have done well enough. And these are basic Indian data which you should know.
ISN member कौन है? ISN member कौन है?
-10 to
मैं है 2700 से 6 से पहले, 2700 से 6 से बाद.
इसके बाद
वोट डाली कि नहीं डाली है? वेरी गुड, चलो जी, यू वांट योर ठीक.
So ये statistical data very important, and lot of big institutions in the country have them. Know about the statistical data of your own institute.
That's very
also.
important.
People will ask you, although examiners are not going to ask you where are you from, which hospital, but they will ask you in your center what is the thing.
Yeah.
That tells whether you have actually been involved in the transplant program at all or not.
What is the commonest etiology? I mean, the way we talk about IgA nephropathies, we take, so absolutely right. Any questions? Any questions? I think the whole idea today was to sensitize you to these definitions, the way you should be analyzing that. Look, if it's a T cell mediated, why does it happen? It happens because you went low on immunosuppression. Because all these years you have been basking in the glory of what cyclosporin or tacrolimus have brought our way. So if you don't use them appropriately, obviously you'll be losing out on the positive effects, and it becomes very, very difficult, you see, because the other side of the story is equally important, and that's CNI toxicity. You can't go away from the fact. But if you have to err on one side, it definitely should be more towards higher immunosuppression, and that magical figure of 5 TAC levels is just about what you should be aiming finally as a maintenance.
Few other topics which you should have gone back and asked. You did not ask the history of immunization prior to transplant, especially pneumococcal vaccine. Once your patient had pneumonia, you should have gone back to that history. You did not ask the history of whether immunosuppression was tapered down or stopped during the pneumonia episode, and you did not ask whether the immunosuppression was stopped when the patient was undergoing plasmapheresis and whether when ATG. It is a very common mistake. People stop tacrolimus or they'll stop ATG or they'll stop oral steroid. Discharge के time पे भूल गया.
Absolutely, and I think you invariably fall in that trap. So you should know this is an art to it as to which one you should stop. Yes, you can do away with the antimetabolites maybe for some time at least, and this is again one of the reasons why patients develop chronic nephropathies. Chronic rejections, because it may not be apparent. It is a forgotten episode that patient had pneumonia, the immunosuppression was stopped, and at the time of discharge the creatinine came down from 2 to 1.5. Patient was discharged, and forgotten episode. What you don't realize is the seeds were sown there, because MMF was stopped rather than reduced. So there's an algorithm for everything. For BK virus, like, you don't suddenly stop as a knee-jerk reaction. You cut down on the dose. So that is why, and you all know it's an evolution. Since you mentioned about BK virus, it's viruria, and then in the plasma, and then into the graft. You know how many of the patients who develop viruria will develop will have BK virus occurrence in the blood, and how many of these finally land up in this thing.
And graft dysfunction, CNI toxicity is the cause. One of the clinical findings which you have to mention specifically is, did the patient have tremors?
Yeah.
Secondly, if the patient had rejection, majority of nephrologists at least at that stage would have shifted from cyclosporin azar to TAC MMF. Kyun, sir? So was that done? Or if that was not done, why? These are things which are very important, which you have to bring out. That look, I asked that after rejection treatment, was his immunosuppression increased or not increased?
History pretty ज़्यादा elaborate होनी चाहिए. Relevant, the way Dr. Mukherjee said, you could have summed up the not so relevant things in one go. So everything is mentioned, yet in a very, very quick and easy to comprehend for the other person. All right, all the information is transmitted. And then I think. Suppose one question. Supposing she said BK virus. Now you do a biopsy, and tomorrow the report comes as BK virus. He is right. BK virus nephropathy. All right, and acute cellular rejection. How do you treat such an entity?
Post-treated rejection, sir.
ठीक है. So पहले जब वो गिरते हैं एयरक्राफ्ट में, माँ को पहनना है और फिर बच्चे को बाद में पहनाना है, ऐसा ये बोलती है ना एयर होस्टेस, कि जब वो गिरेंगे ओवरहेड ऑक्सीजन मास्क, तो पहले खुद पहनना है, बच्चे को बाद में पहनाना है. तो पहले रिजेक्शन ठीक कर लो और बाद में भुगतते रहेंगे बीके वायरस. ऐसा है कुछ? यू राइट, दिस इज व्हाट लिटरेचर सेज. But I don't think that is actually an appropriate way. This is my personal thing, because if you have given 500 milligrams of methylprednisolone to a person with this thing, so yes, you may do that, but in the absence of anything concrete against it, how would you treat? IVIG. So rely more on IVIG, and maybe a lesser than the standard dose of methylprednisolone rather than 500. We have burnt our fingers. The moment you give them, it's the point of no return. उसके बाद तो BK viruria becomes like.
Which is more important, BK virus levels in the blood or urine? Blood.
Levels in the blood vessel?
यूरिन दो ही तो है, CSF में थोड़े ही होगा.
कितने के बाद आता है? So it's 1,000 in urine, 10,000 in urine, 1 lakh in urine.
10^7 in urine.
10 to
Yes.
the 4.
So 1 crore के बाद, 1 crore के बाद blood में आ जाता है, and blood 1000 to 2000 के बाद you have to take notice of it. More than 10,000, so it correlates well with BK virus nephropathy.
What is the strain used for BK virus? Why is that?
Papinicola also.
Why is SV40? Why not use BK virus? SV40 is what? It's the same group, simian virus.
So कैसे पता लगेगा? Acute rejection भी है और BK virus भी है. These are see इतनी बड़ी symptoms.
बायोप्सी करेंगे सर, then we can do donor derived
बायोप्सी में तो
CFTA
ढूंढ रहा हूँ मैं. बायोप्सी में ढूंढो कि ये BK वायरस की. So
8,000.
remember, टाइम थोड़ा है, इससे ज़्यादा नहीं कर पाएंगे. अगर BK वायरस जहाँ पे पाया SV40 सेल्स पॉजिटिव हैं, उसके अराउंड ट्यूबुलाइटिस है, तो ये BK वायरस की वजह से है. So reduce your immunosuppression. While if the acute rejection episode is away from where SV40 cells, positive cells are there, it is concomitant acute rejection. तो अब मुश्किल सवाल आ जाता है फिर IVIG. Steroid, he is right as well. This is what Richard says कि पहले उसको कर लो, फिर उसको एकदम से कम कर दो. Right? So एकदम से कम कर दो और फिर so future क्या है? जिससे आपको डर लगना बंद हो जाएगा BK वायरस से. What is posoleucel?
Yes.
Posoleucel. So CAR T सेल थेरेपी. सो पोसोल्यूसेल एक बाण और कहीं नष्ट कर दिए.
I hope all of you know the definition of tubulitis. What is an artery? How do you define it on a biopsy? I hope you know all these basics. That's why we are not getting into
हम
it.
तो सीधा I1 I2 पे चले गए without even talking about what.
These are basic things you should know. What is a tubulitis? How do you define? What is glomerulitis? What are the 6 minimum stains which are required to say that the biopsy has been adequately reported? I hope all of you know this. No, doesn't look like it. Go and read it up. Read up the Banff classification of 2018 and 22. It has defined everything. What are the stains you have to use? Minimum number of glomeruli, minimum number of tubules, minimum number of blood vessels. How do you define an artery? Everything is given in that. Okay, just there are certain things in nephrology where you can't get away. Dialysis, RO plant, you cannot get away from knowing everything about it. ठीक है?
चलो, okay जी, thank you very much, and I think we